Addington today. So I'll be presenting the theory. Pancytopenia is a reduction in all three hematopoietic cell lines in the peripheral blood. So these cells include the erythrocytes, leukocytes, and platelets. Pancytopenia is not a disease entity, but rather the manifestation of several diseases and signifies the need for further investigation. However, patients may be asymptomatic. Pancytopenia may also be diagnosed incidentally, especially if mild, or it can be present in some critically ill states, such as in sepsis. It is one of the most common reasons for consultation from hematologists. Although there are studies reviewing the underlying pathologies and the bone marrow findings in pancytopenia, only few are published on the approach to pancytopenia in clinical practice. The differential diagnosis in a patient presenting with pancytopenia are broad and extensive. So in terms of causes of pancytopenia, they can be grouped into three broad categories. So impaired production, which encompasses both bone marrow failure disorders and marrow infiltration disorders, peripheral destruction of the different cell lines, and this includes splenic sequestration, and then there can also be a combination of impaired production and peripheral destruction. So how to determine the cause? These three processes can be distinguished from one another by hematological testing, but the crucial first steps of evaluation must include a full blood count, peripheral blood smear, and a reticulocyte count. It's also important to take a comprehensive history and a meticulous physical examination. The reticulated platelet count, though not used commonly, can also be helpful to distinguish if the pancytopenia is due to impaired production or increased consumption. So this lists the common causes. So in terms of impaired production, aplastic anemia can be congenital and acquired, bone marrow infiltrating disorders, which includes malignancy, primary and autoimmune myelofibrosis, granulomatous disorders, metabolic disorders. Also includes nutritional deficiencies, which is vitamin B12, folic acid, and also copper, and myelodysplastic syndrome. In terms of peripheral destruction, it's autoimmune hemolytic pancytopenia and splenic sequestration. And disorders with impaired production and peripheral destruction, paroxysmal nocturnal hemoglobinuria, SLE, drugs, leukemia, hemophagocytic, lymphohistiocytosis, transfusion-associated graft versus host disease, and infections. In terms of South Africa, common causes, a retrospective observational study conducted by Neil and Chapanduka at Tygerberg Academic Hospital. This was done from January 2016 to December 2018. And they found the most common causes were chemo radiation therapy, which was 25%, sepsis at 18%, hematological malignancy at 9%, and HIV was 7%, and megablastic anemia at 6%. So in terms of the approach to pancytopenia, FBC needs to be done to confirm there is pancytopenia, rule out the effect of drugs or toxins. Initial workup should include a peripheral blood smear, iron studies, ESR, CRP, LFT, reticulocyte count, and LDH. If peripheral smear shows macrocytosis, then you can consider a diagnosis of myelodysplastic syndrome, megablastic, or aplastic anemia. So if those diagnoses are not found, an additional workup is warranted. You can do copper, zinc, Coombs, vitamin B12, reticulated platelets, haptoglobin folate levels, and a vital screen for CMV, EBV, Parvo B19, HIV, hepatitis N, ANA. An ultrasound should also be done, in particular looking at the spleen, and next generation sequencing can also be done. Consumption disorders may be identified, such as autoimmune-mediated pancytopenia or splenic sequestration. It's DNA testing done via blood. Yeah.
Just trying to connect, because I always say to medical students, never write something that doesn't make sense to you as a person. So I'm just saying to all of us, I was about to leave, let it go, but I'm just wondering, I'm gonna walk around here and say, next generation students, what?
Yeah, we can order that.
I'm just saying, don't write it if it doesn't make sense. Or at least Google it or ask ChatGPT. And then educate us. This is an educational meeting. I'm just saying to all of us, never write something that doesn't make sense to you, because we are the one teaching people. I'm speaking to myself.
Okay. Thank you. So, let me move on. Let's get a bigger picture yet.
Next generation.
Yeah, suppose it's.
Then for non-nutritional disorders are identified. So we then need to perform a bone marrow biopsy. And this may help us identify malignancy, which could be primary hematological malignancy or metastatic disease, or bone marrow hypoplasia. So acute promyelocytic leukemia during pregnancy. Leukemia is a rare comorbidity during pregnancy with a low prevalence of 1 in 75,000 to 1 in 100,000 pregnancies, the majority of which are cases of acute myeloid leukemia. Acute promyelocytic leukemia is an invasive subtype of AML, accounting for approximately 10% of AML. APL in the early stage may present no typical clinical manifestations, only abnormal routine blood tests. If APL patients do not receive timely and effective treatment, they will experience adverse outcomes, such as maternal and or fetal death. So APL is a subtype of AML with unique molecular pathogenesis, clinical manifestations, and treatment. Cytogenetically, it is characterized by a balanced translocation, T1517, Q24, Q21, that generates the PML-RARA fusion gene. This hybrid gene confirms a particular sensitivity to treatment with anthracycline-based chemotherapy and differentiating agents such as all-trans-retinoic acid and arsenic trioxide, converting this fatal leukemia into a highly curable disease. Cure rates are of approximately 90%. So the epidemiological background, APL is an invasive AML subtype with an age-adjusted annual prevalence of 0.23 per 100,000. Fetal coagulopathy is another important characteristic of APL, and APL occurs more commonly in childbearing and even pregnant women than AML. So in terms of the diagnosis, the diagnostic procedure of APL in pregnancy is the same as that in non-pregnancy period. Bone marrow aspiration and tryphin biopsy can be performed safely in pregnancy. More than 30% of promyelocytic cells in a bone marrow smear is the basic evidence supporting APL diagnosis. Other means are available, such as molecular analysis, peripheral blood microscopy, and flow cytometry, or auxiliary evidence for APL diagnosis. So this is an image of a bone marrow smear of two patients, A, 83% promyelocytes, and B at 79%. So it's more than 30%, which is suggestive of APL. So in terms of clinical manifestations, recurrent infection and fatigue, hemorrhagic risk is another characteristic of APL. Petechiae and coagulopathy are common clinical manifestations. Hemorrhagic coagulopathy is potentially fatal, and life-threatening hemorrhagic disorder, which may result from coagulopathy, is another special characteristic that leads to early death from APL. A population-based report from Sweden by Lehmann et al. Revealed that hemorrhage is the main cause of early death in patients with APL. So in terms of pregnancy and APL, embryotoxicity is a main limitation when drugs are used for APL during pregnancy. APL during pregnancy is rare, so it is unclear whether pregnancy has an impact on the course of APL. When APL occurs during pregnancy, the risk of abortion, perinatal mortality, intrauterine growth restriction, and preterm delivery are increased. The risks of other complications such as infection, inflammation, and placental abruption are increased. A systemic study by Verma et al. Of new onset APL during pregnancy revealed that spontaneous or therapeutic abortion or intrauterine death and neonatal complications, including respiratory distress syndrome, are found in 33.3% and 25.9% of cases. The low risk of transferred fetal leukemia may lie in the natural placental barrier or the immune elimination ability. So in terms of the management of APL during pregnancy, APL treatment for adults is divided into the following three parts. So induction therapy, consolidation therapy, and maintenance treatment. So induction therapy is based on all-trans retinoic acid, ATRA. The consolidation phase involves the use of ATRA and anthracycline drugs, or cytarabine and anthracycline drugs. With this therapy, more than 80% of patients may be cured. The clinical significance of maintenance therapy is still controversial. The discovery and application of ATRA and arsenic have made considerable improvements in APL treatment over the past several decades. Arsenic has high embryo toxicity, so it is not recommended during any trimester of pregnancy. ATRA is a member of the retinoid family and is considered to have high teratogenicity, potentially resulting in retinoid embryopathy. So ATRA should be avoided in the first trimester. ATRA therapy in the second and third trimester is also associated with fetal cardiac toxicity. The necessity of cardiac monitoring should be emphasized. Chemotherapy may not cause congenital abnormalities, but the risk of abortion, prematurity, low birth weight, neonatal neutropenia, and sepsis are undoubtedly increased. Comprehensive evaluation is the fundamental basis of clinical decision-making. This includes the termination of pregnancy and start of induction therapy. Gestational weeks and individual differences in maternal and fetal risk-taking are very important factors. The lack of evidence-based medical and epidemiological evidence suggests that chemotherapy agents and treatment time for APL in pregnancy remain challenging clinical dilemmas. So termination of pregnancy followed by ATRA therapy is recommended because of the embryo toxicity of ATRA when used in the first trimester. Anthracyclines have relatively less toxicity compared with ATRA. Anthracyclines can be used alone in the first trimester, and postponing ATRA until the second trimester is the only but not optimal option for APL pregnant women who insist on preserving their pregnancies. Before therapy is started, the patient should be counseled regarding the poor efficiency and potentially increased risk of bleeding, abortion, fetal death, congenital malformations, low birth weight, and adverse outcomes. Anthracyclines may also affect organogenesis and fetal development. In terms of the mode of delivery for APL patients, it's another challenge that requires careful assessment of patients' general condition. If possible, normal vaginal delivery is preferred to cesarean section to reduce the risk of hemorrhage. Cesarean section is only the best option when a patient cannot endure the stress of vaginal delivery, and these patients should receive ICU care. Multidisciplinary teams are essential for individualized management of hematological malignancies in pregnancy. In addition to ATRA and chemotherapy, supportive blood product transfusion is of great importance. Infection is another common complication among patients with APL. Prevention and treatment of infection is also of great importance. So in conclusion, the increasing incidence of pregnancy-associated pregnancy poses a challenging therapeutic dilemma. The patient, hematologist, obstetrician, and neonatologist should all participate in the decision-making process to obtain a positive outcome for both mother and fetus. The aim of to provide insight into the management of rare APL diagnosed during pregnancy. Timely diagnosis and intervention with ATRA can be life-saving in all cases of APL. Thank you.
Find out about the FMed, this coming Friday at 12 o'clock onwards. We expect everybody to be there. If you are a registrar, free or post call, you can send an apology. If not, you are still stuck in the medical theater. Your consultant must send the apology that I am not Dr. So-and-so and he cannot come or she cannot come. The consultant must say, we are all leaders, we must hold each other accountable. If the register, phone call, whatever, I cannot verify. I'm stuck in traffic. So the consultant must say, I'm here in the clinic or I'm here in theater with Dr. So-and-so. They cannot come.
Is that meeting in this room?
That meeting is here. Where we are.
Are we allowed to ask questions about this citation?
Oh, this one?
Yeah.
Yeah. Instead of a few.
It's the only presentation she presented.
She presented with it, or she was found to have it?
No, she presented with EP
She came and said, I've got a problem. Okay. So she had about 3 important infections. We didn't really hear about the management of those infections. HIV. Was this low CD4 count part of the leukemia?
Yes.
Was she taking treatment well? And is that an issue with regard to the leukemia? Because she was on the normal FDC, was she?
Clearly.
Yeah.
Clearly.
Must have swapped sometimes.
Fixed dose combination. Yeah. Now, what is surprising me is that she had chronic active hepatitis B, and she had extremely high viral load. Why was that? Because what we understand is that if you're on TLD, it should also suppress the hepatitis. So what was that investigated? Furthermore, now she's having bone marrow aspirates and so on. That, this is an extremely infectious patient, and that's a bit of a concern for care. All the people, interns and so on, who are taking a lot of bloods from her and so on. One must take a lot of care and make sure that all such people are immune to hepatitis B. I think that's an important issue in managing these patients, which we must pay attention to. The third thing, did she have a rapid syphilis test that's antenatal care, which was positive, and then she had RPR. So how are these infections managed? Syphilis, hepatitis B, and HIV in the context of this malignancy that she had? Do we start treating these first, or do we put them aside and treat do these cancer treatments kill the infection? I don't know what happens to syphilis when you give therapy.
For the syphilis, she was treated for the syphilis. She received all 3 doses of the vaccine. And then for HIV, she was already on the TLD and nothing was changed at that point in time.
Hepatitis B.
Hepatitis B. I would take the
She's on TLD.
Yeah.
You can't have it.
She was on.
It's on channel for everything. What do you get it?
It seems to be working.
Infectious disease unit and
Yeah, I
can
think
come
she's
so nobody can get that hepatitis that's going able.
Yeah, I'm sure. They're doing that in too.
She's in Albert.
Yeah,
People.
they need an infectious disease testing. But in addition to the lamivudine that is supposed to fight the virus, the hepatitis, you can add, I can't remember offhand, you can add another antiviral for that. I'm not sure which of those.
It's a
it does.
Yeah, but there are other agents. Interferon.
Yeah, no, lamivudine is the original one that is known to be anti-hepatitis. Then of course, tenofovir. So you can add, as I said, there are other drugs.
The TLD, what does it have? Does it not have all tamivudine and tenofovir? It's got both. So let's leave that to the experts. They will, I'm sure they'll deal with that part. I mean, it's a complicated case. I mean, the primary issue here is leukemia that needs to be dealt with the other peripheral issue. Bicillin is the treatment for syphilis, so she will be given bicillin anyway. In terms of that, hepatitis, as we say, she was already on that. Whether she's responding or not, it's another story that needs to the experts.
And I think the ethics of what to do with this baby at 24 weeks. Maybe we need a follow-up with the team at Albert at some point to give us closure on this patient. It's an interesting case. What did they do? It's a very borderline gestation. Whether you use your undersides or whatever, or you prioritize that she's 41. And yeah, you know, are we going for baby viability? Are we going to optimize maternal condition? And how long? That's why I'm saying maybe they can give us a summary at some point about what eventually. Can't just leave it like that.
Yeah, I'd spoken to that.
We had initially considered the tumor.
Where is she? You're at Albert now.
Also, everything with the two from us, she had this with cancer treatment from their side, the acid from their side. She refused she declined the GOP. But we also,
No, not you.
No, what are you saying? What did you, what were you offering at POV?
but she was offered.
Sorry?
She was offered. She had,
Offered what?
we can't.
On what basis?
This is initially that she was the chemo, they were worried about the.
Exactly.
We don't have enough evidence to say one thing or the other. I mean, you know, saying termination, I mean, it's a difficult story. And if we're going to offer patient at 24 weeks, we should put ourselves in the patient's shoes and say, I mean, it's involve the whole family to come and say, now they go around and say there are doctors who want to kill babies and what. No, I mean, we don't know. Patients have been given this kind of treatment in the second trimester and third trimester. So there is a possibility of cardiac toxicity of the baby, but not to any other anatomical abnormalities that have been identified. So I don't understand why would somebody talk about termination.
No, we didn't say she was terminated.
You offered her and she declined.
Also, she said she died.
No, you offered her something that's not based on any scientific story.
I think Dr. Michael said they were worried that it was a very aggressive tumor.
Yeah.
So they were thinking that if she doesn't respond to the first line of treatment, they might need to move to the second line. So they canceled their on termination on those bases. Then they would need to give her anti-cancer treatment that might be more teratogenic than what they're giving her in case she doesn't, because the type of tumor that she has.
It might be Dr. Maisa, it might be an issue of words that we are using. Whether we said TOP or they gave the patient the scenario that the drugs we are using
Yeah.
have potential to damage the baby.
Yeah.
So we are not sure, and I'm looking here, none of those three consultants at Albert are here online to say what did they
The
say.
reason I'm saying that, I've also had a patient with I think it was what's the other hematological condition, malignancy, lymphoma. And the drugs that they were going to give were definitely were going to harm the baby even after the second trimester. She said no, and she continued, and we eventually delivered it. So what I'm saying is that one should not be saying something that's really not based on anything. Yes, we're going to give you the treatment. Now they're saying to the patient, we might need to go to the second line. They don't know that, whether they'll go to the second line. If we get to that point, then that's when we offer the patient the options in terms of that. But you can't just start by offering something like kill the baby. That's what we're saying to the parent. Let's kill the baby. No, that's not correct.
So much. Continue.
The baby is still family didn't have to solve for her.
Please, Anna.
He's
I think she must be true.
so we did an ultrasound yesterday. The baby's looking mild. Just stay it's bad. Baby's still fine.
How's the mother? The mother was.
Initially, they kept her isolated, but we got us going to basically prove in the 8 cycles. Last time we saw it in the achieve of 8 cycles.
She was on our child when we first transferred her, transferred to Norton. And then they were going to be 100%.
So ultra is this very one that is toxic.
Yeah,
They
The
did.
retinoid based
they
one.
actually look at such an aggressive phenotype.
So they didn't start with the one that we think is safer. They went to the other.
So she's in the early stage trial. Sorry, it's still one day.
Because that one is more, well, the first child. With the definitely. And I think because she was pregnant, she was, doing it for time they started the action.
Interesting, let's find out what happens now.
And now she's got a DVT. Now she's got a DVT.
I was actually thinking the same
Yeah.
thing that, you know, it's high BMI, she's immobilized, I'm going to be.
But the third one is going to be. It's highly that.
It's isolated, so you will know. Not allowed in there. Thank you.